Welcome, everyone. Today, we are going to tackle one of the most persistent challenges in medical research, bias. Specifically, we are looking at common biases in observational studies and how to mitigate them. If you work in research, pharma, or clinical practice, you know that data is never just numbers, it's a representation of reality. But between reality and our observation of it lies a filter that can distort the truth. That filter is bias. Over the next few minutes, we are going to look at these biases as traps and, more importantly, discuss the specific strategies you can use to design them out of your studies. Let's dive in. First, let's contextualize why we are here. We live in the era of real-world evidence, or RWE. Observational, non-interventional studies have become the cornerstone of generating this evidence. Unlike clinical trials where we control every variable, observational studies give us a window into how treatments perform in the wild. They provide critical data on drug safety and effectiveness without the artificial constraints of an intervention. Why does this matter? Because these findings don't just sit in journals, they directly inform regulatory decisions and shape healthcare practices across the region. When the stakes are that high, affecting patient safety and approval decisions, the integrity of the data is non-negotiable. We need RWE, but we need accurate RWE. This brings us to the core conflict, the challenge of validity. While these studies offer incredible insights, they are inherently susceptible to systematic errors. Look at the graphic on the screen. You have reality on the left and your observation on the right. In the middle is the lens of bias. If that lens is distorted, your observation will not match reality. You might find a drug is effective when it isn't, or dangerous when it's safe. The objective of this presentation, and your goal as researchers, is to realize that awareness is not enough. You cannot simply acknowledge bias exists. You must implement proactive mitigation strategies. We need to ensure that what we find represents true relationships, not just artifacts of a flawed study design. Let's open our field guide and look at the first trap, selection bias. This occurs when the participants you select for your study do not actually represent the target population. If you select participants in a way that affects the outcome, you've introduced a systematic error before you've even collected a single data point. How do we fix this? First, random sampling. By selecting participants randomly, you minimize systematic exclusion. Second, stratified sampling. This is where you divide your population into strata, like age groups or gender, and sample randomly within those groups to ensure everyone is represented. Finally, matching. If you are comparing groups, pair participants based on key variables to ensure you're comparing apples to apples. These strategies ensure your study population actually looks like the real world. Next up is a very common issue in retrospective studies, recall bias. The diagnosis, human memory, is flawed. Participants may inaccurately remember past events, exposures, or behaviors. If a patient believes a specific exposure caused their illness, they may remember that exposure more vividly than a healthy control patient would. This leads to skewed results. We have two strong solutions here. Number one, use objective measures. Stop relying on memory. Replace self-reports with verifiable data sources, like medical records or electronic monitoring. Number two, blinding. Keep participants unaware of the specific study hypotheses. If they don't know what you're looking for, they are less psychologically inclined to alter or fit their responses to meet your perceived expectations. Now we arrive at perhaps the most important trap in epidemiology, confounding bias. This happens when an extraneous variable, a third wheel, is associated with both the exposure and the outcome, distorting the relationship. For example, coffee drinkers might look like they have higher cancer rates, but if coffee drinkers also smoke, smoking is the confounder, confusing the data. We tackle this in the design and the analysis. In the design phase, use a controlled study design with rigorous matching and stratification. In the analysis phase, use statistical adjustment. Utilize regression analysis to mathematically control for these potential confounders. And while randomization is primarily for experimental studies, understanding its logic helps us. We want to distribute confounders evenly across groups so they cancel each other out. We've talked about the participants. Now let's look in the mirror at observer bias. This is where our expectations as researchers influence the outcome. If I believe a treatment works, I might subconsciously interpret ambiguous data in a favorable way or ask leading questions during data collection. The gold standard solution here is blinding or masking. Keep the researchers unaware of key details, such as which participant is receiving which treatment or their specific characteristics. Additionally, implement standardized protocols. Enforce strict training and standardized procedures for data collection. If everyone follows the exact same script and measurement technique, you remove subjective influence and consistency reigns supreme. Our final specific trap is measurement bias. This arises from systematic errors in the tools or procedures we use. If your scale is always 2 pounds heavy or your blood pressure cuff is uncalibrated, every single data point you collect is wrong. To solve, you need first validation of instruments. You must rigorously test your measurement tools to confirm they accurately measure the intended variables. Second, calibration. This isn't a one-time task. You need regular maintenance and calibration of instruments to maintain accuracy and reliability throughout the entire study lifecycle. Don't let your tools drift over time. Let's bring this all together. On this slide, you see a summary of the biases we've discussed. Selection bias, we counter with random sampling and stratification. Recall bias, we move to objective measures and blinding participants. Confounding, we use regression analysis and matching. Observer bias, we blind the researchers and standardize protocols. Measurement bias, we focus on instrument validation and calibration. I encourage you to keep this framework in mind. When designing a protocol, go through this list checklist style. Ask yourself, have I accounted for selection? Have I accounted for recall? We'll close by looking at the strategic impact of this work. Why do we go to all this trouble? It comes down to 3 pillars: validity and reliability. Rigorous control measures directly enhance the credibility of your findings. Without this, your data is noise. Scientific contribution. By neutralizing bias, you are making meaningful, enduring contributions to scientific knowledge. You're not just publishing a paper, you are adding to the truth. And robust evidence. Most importantly, proactive steps ensure research outcomes are credible enough to support regulatory and medical decision-making. In the world of real-world evidence, our goal is impact. By mitigating bias, we ensure that our insights lead to genuine improvements in patient care. Thank you for your attention.